Hi everybody, Ziv Simon here. I'm the creator of SurgicalMaster. Welcome to this video. Today I'm going to talk about sinus communication or perforation after extracting an upper molar, which is a problem that we see every once in a while. Now, the idea for this video came from a dentist practicing here in California, Dr. Delia Tuttle, who posted a case online where she showed this problem and asked about the management and some of the thought process. So I created this video on this topic. I met Delia a few months ago while giving a lecture in Temecula. And it took me about 3 hours to drive there in traffic, and I only had about 5 minutes to prepare for my presentation and not eating anything, not drinking anything. So she came by and she offered me some coffee that really helped me. So Delia, thank you so much for your help. I hope you enjoyed this presentation and keep up the great work.
The idea behind this video comes from a dentist by the name of Delia Tuttle, practicing here in California. She is originally from Romania, where she also got medical training. She's a trained physician, now practicing dentistry here in the United States. And I got to know Delia through the online community where I was following her posts, and she's a great dentist. And she also has great surgical skills, and she constantly posts her cases. I'm always impressed by the quality of the work and her willingness to learn and improve. And also started a movement called Follow the Pink. And that really impressed me because her goal is to promote periodontal health, promote the soft tissue aesthetics. And that's also the name of her brand. And I really love it. And I decided to make this video following a question that she posted online. And she showed a case where she extracted a tooth and had a sinus communication. She was asking what should be done if this happens after an extraction. What is the thought process? What are the clinical steps that you need to take? What are the different scenarios? So Delia, this is a video I made just for you. So we all know that when it comes to upper molars, the roots of the teeth are very intimately related to the sinus. They're very close, and that can potentially create problems when we're dealing with extractions of upper molars, and also later on when it comes to placing implants and needing to do some vertical augmentation through a sinus lift. So when it comes to tooth extraction and a possible risk of communication, there are two scenarios that we're typically dealing with. You can have a root apex that is relatively high, even part of the sinus floor. And you can also have a large periapical infection that slowly, gradually invades the sinus space. I call this a high apex for those anatomically high roots, or an infected apex. And by the way, you can have both scenarios happening at the same time. So in order to understand what happens there, we need to understand the path of infection. So when we're dealing with the maxillary molars that, to begin with, anatomically are close to the sinus floor, once an infection occurs, and that could be of endodontic origin mostly, but also periodontal, the infection can be persistent and even sometimes asymptomatic without invading the sinus space for a very long time. The sinus floor is made out of dense cortical bone, and that will many times direct the infection away from it and also protect the sinus. Now, at some point in certain situations, the infection is locally destructive, and as the infection grows, eventually it can resorb the floor of the sinus and start invading the sinus space. And at that point, for the most part, you'll start seeing that the sinus membrane or the Schneiderian membrane starts to react, becomes inflamed, and the sinus condition becomes pathological. And some patients may even develop symptoms. By definition, they will be suffering from sinusitis or sinus infection and inflammation. So the infection will go through the path of least resistance, and if you extracted a tooth in this situation, you will automatically have a perforation into the sinus, which is a problem. Now, some roots are actually forming the floor of the sinus, and you can see this very clearly on CT scans. If you look very carefully into the sinus cavity, you'll see the roots of the maxillary molars protruding in. Now, they can have a bony separation around them, but in some situations, there is no bone. There's just a very thin layer of membrane that covers the apices of the roots. When you extract this tooth, a perforation is inevitable. Now, you don't have to get a CT scan for every upper molar extraction, but it can be advantageous in certain situations and will help you prepare and also prepare the patient for some possible complications and side effects. So let's look at a few clinical situations where you extracted an upper molar successfully, and when you looked into the socket, you saw a small dark structure, which is basically the sinus space showing through the extraction socket. And I call this a pinpoint visible communication. Now, the smaller they are, the faster and easier they heal, and it's really not a big complication or problem. But as those communications get larger, and usually it happens when it is a combination between a high apex and a large infection, you need to take the necessary steps to make sure that this communication is not persistent and causes more problems in the future. Now, on some occasions, once you extract the tooth and you may be suspecting of communication, you can't really see because of bleeding and debris in the area. So in these situations, you need to test for a sinus perforation, and one of the ways is to perform a Valsalva test. And this is a very old thing in medicine in general, but the way it's adapted into dentistry in the extraction of upper molars, the patient will exhale while holding their nostrils closed. Basically, they'll blow their nose. I suggest you let them block the nostrils and just tell them to hold on, position your mirror right below the extraction socket. Make sure that you have good illumination, position your mirror properly, and then ask them to blow their nose, not too forcefully, gentle to moderate pressure, and look at the extraction socket. What you'll start seeing, if there is a communication, you may see bubbles, you may see air coming out depending on the size of the perforation. And this test will give you a confirmation that there is a communication with the sinus, and that is something that you need to address. Now, when this happens, you have a few options. It will many times depend on the size of the perforation and also the location of it. And a very simple option, especially for those visible pinpoint perforations, is to place multiple layers of collagen or collagen plugs. You can also use platelet-rich fibrin plugs, which is my preference, and basically suture with an X suture, for example. And for the most part, this perforation will correct itself. Option 2, if you're planning an implant in the area and you'd like to do some bone grafting, naturally, it's not a good idea to place bone graft into the perforated socket because your condensation will push the bone graft into the sinus cavity. So that's not a good idea. But what you can do, you can layer the perforation with collagen, and again, platelet-rich fibrin, and layer the bone graft on top of it. Now, in the root that has the perforation, I would use very light pressure in terms of my bone graft condensation. Again, for obvious reasons. If you put too much pressure, there's a risk of dislodging everything into the sinus. So light pressure, look at it as almost like a conventional socket graft. I layer a collagen or PRF also at the occlusal part of the socket and suture up. And for the most part, this will heal very well spontaneously. Now, you may still need to do a sinus lift for the implant, but the perforation will correct itself and the membrane will reform. And we're looking at a CT scan taken a few months after the extraction. And in this case, the membrane healed, the bone healed, and now I'm planning for a sinus augmentation procedure because there's still deficient vertical height for an implant. So these are the relatively simple ways to manage these perforations. Now, on very rare occasions, you will have a communication that will not heal, no matter what you do. And this is a very tricky situation, very uncomfortable situation for the patient, because if you think about it, if there is a constant communication between the oral cavity and the sinus, every time the patient is drinking something, it'll go inside the sinus and then it'll come out through the nose. And often food debris, bacteria will constantly infect the sinus. So this is a very bad complication, and luckily it's relatively rare. And before you jump in and try to repair it and try to close this communication surgically, I'd like to tell you that this is not an easy thing, because when this occurs, the reparative surgical procedures for this situation don't work as well. And often it takes 2 or 3 attempts to close the communication before it actually works. And the reason it doesn't work so well is that once we are at this point, the sinus is completely infected and full of food debris and bacteria that will cause the failure of these surgical procedures. So the first goal, in my opinion, in my recommendation, is to stop the food impaction into the sinus. And many times it's done by making a removable obturator, which is a type of removable appliance that has a little plug. It goes right into the perforation so the patient can eat with it and prevent food from going in there. And number 2, involve an ENT specialist in ear, nose, and throat to work together to clean the sinus and do what needs to be done. The actual procedure can be 2 ways. It could be by advancing a buccal flap or with a rotated palatal flap to close this communication. And again, don't jump into these surgical procedures without making sure that the sinus is not getting food impaction and working as a team to fix this problem. So upper molars can get very tricky when it comes to extracting them, especially with large periapical infections and the roots being anatomically close to the sinus or inside the sinus. And you need to be able to speak to the patient about it. You need to be able to anticipate this problem, making sure that you have all the tools, instruments, and materials available in your practice to fix this problem if it occurs. And when the tooth comes out, you need to be able to verify the communication, whether it's visually looking into the socket or by doing the Valsalva test that I described before. And once you verified it, you need to be able to manage it. And I showed you a few options how this can be done. Without exception, you need to monitor all of your patients and making sure that the extraction socket heals properly until this communication is completely closed. So for this tooth, after I extracted it, there was a lot of pus, not just in the socket, but draining from the sinus. So the sinus was very heavily infected. So what I did, I took a small suction tip, put it not just in the socket, but in the sinus, and it took about good 10-15 seconds to suction all the pus out of the sinus. It sounded like a Coca-Cola commercial, somebody drinking out of a straw. And at the end of the process, the patient said, "Thank you so much. I can now breathe." So what happened, the dental infection caused the sinus to get infected, and that was interfering with the patient's breathing. So we really did the patient a big favor. Now, if you have a big communication like that, you need to do your best to close the socket primarily if you can. Clean out the infection, use your collagen layers, your PRF, but as much as possible, close the tissue and the flaps primarily to prevent this communication from staying persistent. And as you can see, it healed quite well with no major side effect, and the sinus overall health has also improved. So to conclude this presentation, extracting teeth with a large periapical infection that affects the sinus is a big service to the patient. It has a couple of risks of having a small communication that could be visible and mostly heal spontaneously. And sometimes large communications take a little bit longer, but they will heal. And the ones that don't heal need some more intervention, and I recommend you work with a specialist on these cases. So Delia, thank you so much for bringing up this topic for discussion. I hope it was useful to you when it comes to sinus communications. Thank you also for being such a great supporter of the periodontal health and the soft tissue aesthetics in everything that we do, and your brand, Follow the Pink. I'm a big fan of yours, and I really appreciate what you and your practice are doing. If you found this video useful and valuable, feel free to share it with other dentists and leave me some comments below. You can also go to SurgicalMaster.com and sign up, opt into my weekly emails and blogs so we can learn together and get better. And I really look forward to seeing and working with you in the future.